Hello and welcome to Unstressed. My name is Dr. Ron Ehrlich. Now, before I start, I would like to acknowledge the traditional custodians of the land on which I am recording this podcast, the Gadigal people of the Eora Nation, and pay my respects to their elders, past, present, and emerging. Now, when I say past, they have occupied this land for tens of thousands of years, at least, and we have much to learn about respect for people and country and connection for people and country. The two are inseparable. Well, today we are exploring the world of mental health in general and the world of antidepressants in particular. And there are some very sobering statistics and points that we make during this discussion. I believe we have a healthcare system that is focused on chronic disease management. And I also believe that we have a model that is a great economic model, just not a very good health model. And if you wanted an example of that, our approach to mental health in our community is perhaps the best example that we can pick. Now, my guest today is Dr. Mark Horowitz, and he is a collaborating investigator on the release trial in Australia, investigating supported, gradual, hyperbolic tapering of antidepressants. Now, it's sobering to learn that 1 in 6 Australians are on antidepressants, and there is a great deal of misinformation about how one could possibly come off those medications and what the alternatives may be. He's a member of the Critical Psychiatry Network and an associate of the International Institute of Psychiatric Drug Withdrawal. He's also co-founder of Unstress Health, which helps people who wish to stop unnecessary antidepressant medication in Canada and the US using gradual hyperbolic tapering. Look, we discussed this, and if you're listening to this in Australia, the information is accessible to you. We will have links to that. I hope you enjoy this conversation I had with Dr. Mark Horowitz. Welcome to the show, Mark.
Thanks for having me here. Great to meet you.
Mark, I was introduced to you through our mutual friend, Jocelyn Brewer, who's been almost a regular on my podcast dealing with digital nutrition, the world of technology and its influence on mental health. But I want to just take a step back about mental health because it's a huge problem. And the Diagnostic and Statistics Manual, the DSM, is what is generally the code by which practitioners assess mental health. And I know the DSM-1 was about 150 pages. It was quite short. The DSM-5, the more recent one, I think about 15 years ago actually, was about 900 pages. Have we pathologized life? Is anyone normal?
It's a good question. Actually, there's been two things that have changed in the DSM from 1 to 5. One, you've pointed out, is the volume, the number of disorders that exist. But the second one, I think maybe the most important shift, actually happened in the DSM-3, and it was a shift from describing mental health symptoms as reactions to illnesses. So in DSM-1 and 2, it was very psychoanalytically based, and everything was a reaction. There was depressive reaction, there was anxious reactions, there was psychotic reactions. And the reaction was reaction to life, to grief, to losses. That was the central understanding of why people became depressed or anxious. And in DSM-3 in 1980, under Robert Spitzer, psychiatry was under attack by psychology, as it still is, in that what were psychiatrists doing that was different from psychologists, and why did they cost so much more? And DSM-3's answer to that was, we are doctors and we treat illnesses. And that involved an intellectual exercise where depressive reaction was turned into major depressive disorder and anxious reaction was turned into generalized anxiety disorder. These were conditions with capital letters that sounded the same as myocardial infarction or diabetes. And what psychiatry was saying is, we are medical doctors, we treat medical disorders, often with what was starting to be medication more widely at that time. And that was a very big turning point in the history of our culture, because suddenly we went from talking about the things that made us depressed and anxious to conditions that were depression and anxiety became decontextualized. So in DSM-3 through to 5, major depressive disorder is defined by 5 symptoms out of 9 with no reference to what's happening in life. So if you are, sleeping more, down in your mood, you're your appetite is lessened. You have major depressive disorder. The context of, has your mother just died? Have you just lost your job? Are you suffering from poverty? That is suddenly removed from the situation because we're now doing symptom checklists. And along with that, like you said, we now have hundreds of disorders. So I'll give you a quick test here. I'm sorry to turn the tables here. By the age of 45, have a guess what proportion of people meet criteria for a DSM mental illness. Have a guess.
I would guess about 80% or 90%.
Okay, well, you're a very well-informed contestant on my show, because the answer is 86% of people.
86%. There we go.
Most of that is depression or anxiety. So by the age of 45, 70% of people will meet the criteria for major depressive disorder or generalized anxiety disorder. In other words, it's more of us that don't. It's more of us than don't.
Doesn't that speak to a much bigger issue, which I have been following professionally for over 40 years, and that is the business of medicine? I mean, the more people that can be diagnosed with a disease and then managed makes very good business sense. And one only has to look at the evidence, because we are very evidence-based, and the evidence shows us that the pharmaceutical industry is now worth US $1.5 trillion. And I would argue that the medical profession has been a very major facilitator of that growth.
Yes. So it's been said that drug companies market conditions more than medications, more than products, because you cannot get a drug licensed for no reason. It has to be licensed for a specific indication. So, as an example, obesity was recently listed as an illness, which has allowed different drugs to be licensed for. That's why there's been this huge outpouring of drugs for obesity. And so, if you there's a great example of this in England. I don't know the Australian example as well, but I think it's very similar. In England, there was a education campaign called Defeat Depression. It ran during the 1990s and 2000s. The message was for the public to tell them that feeling down and low was a medical condition, and you should go see your doctors about it. The two major barriers to that they found out from the public was that the public believed that being depressed was caused by life circumstances, by divorce and illness, and that if there was any medication to be used to treat depression, it would likely be dependence or addiction forming. And so the campaign set about dissuading the public from those two ideas. They told them that no, feeling down was an illness called depression. It wasn't about life. It might be precipitated by life, but it wasn't just about life. It wasn't just sadness. And two, that medications for depression would not be dependence form, would be easy to stop. That campaign was fronted by the Royal College of General Practice and Psychiatry, but it was funded by the drug companies. And it went from the beginning of that campaign, I think there were about 3 in 100 people were given antidepressants. By the end of the campaign, 1 in 6 of the public was given antidepressants. So it was a huge boon for drug companies. The expansion of the market was by 500%. And now we exist in the world created by that education program, that our moods are illnesses, and that medications are, that because it's a medical condition with a chemical cause, that a chemical solution makes sense. And so we are living in a vastly over-medicalized world, and that message was delivered, as you've indicated, by the medical profession, because in many ways it expands their power as well. Because of course, the USP, the unique selling point of psychiatry is that it offers medication for emotions.
For a diagnosable illness.
For a diagnosable illness, exactly.
Yeah. Well, I had the pleasure of interviewing Dr. Martin Whiteley, who's written a wonderful book called Overprescribing Madness, and I will actually re-release that episode in the same week that this has come out. So for our listeners, they can listen to that in the coming week. But Martin pointed out, and I might say that to read his book online, the last 60 pages have got references hyperlinked to the reference. So you want to read evidence, there it is. He shared with me that 95% of antidepressants are prescribed by GPs, and that and considering the average appointment time for a GP consultation is 10 to 15 minutes. Now, Mark, you're a psychiatrist. I'm fairly certain that your appointments to get into the mental health of your patients wouldn't get very far in 10 to 15 minutes. Am I right in saying that?
I mean, you're right. I think I don't know if it's 95% or 85%, but you're definitely right. It's definitely the vast majority of medications is prescribed by GPs. That's true. You're right that GP appointments are short. I mean, what has been, I don't blame GPs. Sometimes people think that I'm blaming GPs. I don't at all. They're just doing what the system is forcing them to do. I think GPs are in an incredibly difficult position because all the problems with modern society are washing into their waiting rooms. So they are being forced to deal with the product of poverty, of inequality, of job problems, relationship issues. It's all on their desks. So they're in a very tough position. And given that, I think a lot of them reach for a prescribing pad because there's not a lot else you can do in 10 to 15 minutes. I do think those are, they're going to be superficial assessments. You're right. I guess one of the advantages of being in psychiatry is you have more time to assess people and to understand what the context of their lives are. I do think that because we have medicalized these conditions, people think it's the same as treating blood pressure, because you can treat blood pressure in 10 to 15 minutes. If someone has high blood pressure, there's a medication for it. There's a guideline. You follow the guideline. I don't think depression or anxiety really fits into the same box as that. It's not as neat. It's much more connected to people's lives. And I think that putting it in this kind of medical machinery has created this overprescribing culture that we live in at the moment.
I mean, it is interesting that you draw the distinction, and I hadn't really thought about it, that the DSM-3 was a reaction to psychiatry versus psychologists. Yeah. But at the end of the day, the majority, would I be fair to say the majority of psychiatrists, even with an hour-long appointment, ends in a prescription?
So I think I read somewhere that 97% of interactions with the psychiatrist involve medication. I don't know if that's an American psychiatry, but I think, more and more these days, medication is the main tool being used. There are lots of psychiatrists that focus on psychotherapy. It's still a part of psychiatry training. But I do think it's generally the main tool used, and that's definitely fair to say.
And given we are living in a world where we're constantly reminded in medical profession that it's evidence-based, and considering that these medications are designed supposedly to correct biochemical imbalances in the brain, how is that measured?
It's a very good question, Ron. A colleague of mine called Michael Hengartner wrote a book called Evidence-Biased Medicine, where he put in one letter to evidence-based. And I think that's very useful because, one thing about, I'm a scientist. I've done a PhD. I've got several degrees. I can't stop doing degrees. So I'm into the evidence. But the issue is that the evidence base is socially constructed. The evidence base is conducted by people that pay for the evidence. So, for example, when it comes to medication, to antidepressants, 97% of studies are funded by drug companies, and they're designed in a way to make their products look good, because companies do not produce studies that make their products look bad. That is commercially not a viable strategy. And so they do all sorts of things to dress up medications. You've pointed to one aspect of that, which is the story behind medications. So this idea of chemical imbalances. So the first question you've asked is, well, what is a chemical balance? If there's a chemical imbalance, what's a chemical balance? And of course, the honest answer is we don't know, because the chemistry in the brain is changing all the time. It's very hard to measure. So it's very hard to say what is a chemical balance or what does a chemical imbalance mean. Really, what this comes from is chemical imbalance is the colloquial description of a hypothesis, the low serotonin hypothesis, that's been around for several decades, that came up in the 1960s by psychiatrists in America, where they basically worked through the following syllogism. If medications that increase serotonin improve people's moods, then maybe low moods are caused by a lack of serotonin. It was a legitimate hypothesis, and there has been 6 decades of study to look at, is that the case? And we wrote a paper on this a couple of years ago now, where essentially none of these studies found any differences between healthy volunteers and depressed people. So it's not true to say that depressed people have low serotonin. It's not true to say they have a chemical imbalance. Why has that idea become so prevalent? It's because drug companies push that out everywhere. In Australia, we don't have direct-to-consumer advertising, but in America they do. And in America, there was ads on TV saying, they had sad little blobs walking along, no friends, grey sky. Why are they sad? Because they don't have enough serotonin in their brains. If you give them Zoloft, a very popular antidepressant in Australia, still sertraline, it will increase their serotonin. It will fix up their chemical imbalance. And so that message has been pumped out by by advertisers. It's also been put out by professional bodies. So the Royal College of Psychiatrists, the American College of Psychiatry, the Royal Australian College of Psychiatry have said for many years, I think maybe recently they may have updated it, but for many years they said depression is caused by a chemical imbalance, and that these drugs can rectify the imbalance. I think that talk about the evidence says that is not true. That is not an accurate statement, and I think it's misleading to say to patients. Many people have been told that. If you survey the public in Australia, 90% of people believe that depression is caused by a chemical imbalance. Similar in America. So that messaging has come out very effectively. We also know that if people believe that their depression is caused by a chemical imbalance, they're more likely to take medication because, of course, chemical problem, chemical solution makes sense. They're more likely to be pessimistic about their chances for recovery because they've been told there's something fundamentally wrong with your brain. They're also not just likely to take control themselves because, if you've got some sort of chemical problem, it's very hard to fix it yourself. You need to go to an expert with a chemical solution. So it tends to make people more pessimistic. People who believe that their depression is caused by life circumstances, a rough patch, difficulties, are more likely to be optimistic about recovery, are less likely to take medication, and are more likely to think that they have it within themselves to make changes to their lives to get better. So I think this narrative of a chemical imbalance is both not supported by evidence and also a demoralizing, unnecessarily negative explanation to give to people. And the last thing I would say is, referring back to what I said before, if 70% of people have depression or anxiety in their lives by the age of 45, it would be pretty strange if 70% of people had abnormal brains. It's what's normal if 70% of people have something. So I think that the chemical imbalance idea is misleading in many different ways.
But it's an idea, well, it's a great economic model, Mark. It's just not a very good health model, which goes a long way to explain our healthcare system.
Yeah.
But it's perpetuated continuously in an almost tsunami-like, voices like Martin Whiteley's or your own. And I know Martin said to me, this is great. The podcast comes out, the book comes out, it's reviewed for a week, and it may change a couple of minds, but then the tsunami of information takes over, doesn't it? And with a busy, and I agree with you, I do feel for general practitioners, they're put in a very, very difficult position where they have to do something and they're overwhelmed. And this is actually acceptable and expected response. Exactly. So it's a perfect system, isn't it? It's just not a very good health system. Great economic model, not a very good health model. The other one that I found really interesting before we dive into this whole discussion about antidepressants is the influence of, I know there was a great article in the British Medical Journal in April 2022, it was an opinion piece on key opinion leaders and product champions. And when it comes to antidepressants, I think the same can be said for statins. And one could even argue vaccinations, but I don't want to go down that path. But certainly statins would fall into this category. The product champions, the key opinion leaders, sit in positions of enormous authority and power.
They do.
Is that your observation?
It is. I can't speak to statins or vaccines, but I can talk about antidepressants certainly. So, look, we don't have direct consumer advertising in Australia. The most important market to advertise to is to doctors because they're the ones who prescribe medications. Drug companies cannot give medications to patients. So that is an important constituency to market to. Doctors think, or people maybe think, that the way that drug companies try to influence doctors by giving them pens or expensive trips to Hawaii, I think that happens less likely. That happens less often now, but that was never the main way that people marketed to doctors. The main way to market to doctors is to publish papers in the New England Journal of Medicine and to have professors from Harvard and Oxford and Stanford and UNSW and Sydney University give lectures about how effective, safe, and easy to stop these medications are. And so what drug companies spend a lot of time doing is, as you say, they cultivate relationships with key opinion leaders in the same way as a perfume company may pay Kim Kardashian to put their product next to her dancing. Drug companies will pay professors at the big universities in Australia to become the spokespeople for their drugs, and these people will be in the media putting out positive stories. They'll be giving lectures at medical conferences, and there'll be a tiny little asterisk at the bottom of their lecture saying sponsored by Janssen, AstraZeneca. But that's become so common in the lecture circuit, people don't even notice it. It's just people make jokes about it. There's a lecturer in England who we used to have a long list. So he would say, when it comes to taking money from drug companies, people are either promiscuous or they're completely abstinent, and I fall into the former. And he would show a long list of drug companies he took money from, with a bit of a giggle from the audience because he's made a bit of a joke of it. So it's become incredibly normalized. And these people often, the people that are recruited are the people that are in good positions. So they're leveraging their authority. And of course, the support from drug companies helps these people's careers, go forward, because what happens when you're associated with drug companies is they send you papers, they send you studies that are going to the Lancet and the New England Journal of Medicine to put your name on it. It makes life very easy for such people. They have excellent publication records, they get promotions, and so their careers, ascend along with the messaging from drug companies, and they are embedded in the landscape of medical education. And that means that doctors are walking around. And I remember this when I was a student and when I was a young doctor, thinking, I'm a very critically minded, very clever person. I can spot a weasel from a rabbit, and I had no idea, how stage managed what I was being taught was. Even what we were criticizing, even that was within the bounds. And I really didn't see that until I hit, right into my face, information that contradicted what I was being taught, which was me coming off my own medication and seeing that it didn't match the textbooks at all. But up until that point, I was, as hypnotized by this educational machinery than anybody or anyone else. And I think these key opinion leaders play a very big role in perpetuating these myths.
Yes, well, I think it's a story that is very easy to miss, but once you hear it, very difficult to ignore. The overwhelm that doctors face, not only in their patient load, but in the research that they are meant to keep up with. I always laugh when I hear a doctor say, there's no evidence to support this, which suggests that they've read all the evidence. And I think it takes about 600 hours a week to stay up to date with all the evidence. But there's also about curiosity that I find most intriguing in the medical profession, because the curiosity for health seems to kick in only after a doctor studies pathology and pharmacology, because they go so well hand in hand, and they really do go to the heart of what you believe a doctor is all about. Whereas if we bothered to remember our biochemistry and physiology, we may have a different view of that.
My takeaway is the education that you go through in medical school and psychiatry, makes you think about things in a machine-like way. And I think it's more appropriate to physical health, although I think there's big limitations to that as well, because I think, but I'll stick to my field. I think, doctors everyone likes a simple model, I think. So I remember when I sat in a lecture and the big professor at UNSW showed us that, mild to moderate depression was caused by low serotonin, and severe depression was caused by serotonin and noradrenaline problems, and psychotic depression was caused by serotonin, noradrenaline, and dopamine, with these sort of neat diagrams, different overlapping circles. I thought, this is brilliant. I mean, I was reading Nietzsche and Kafka and Dostoevsky and, trying to work out, I was a young man, why am I so screwed up? What is the meaning of life? And suddenly, on a diagram, on a lecture, all of this stuff becomes resolved into three chemicals. I thought, I've lucked out. This is the greatest lecture I've ever been in. Suddenly it all makes sense. And of course, we have medications that match each of those neurochemicals. So I thought, I have seen into the heart of what it is to be, human and ill. It was so compelling. And I think that's the sort of thing that, sticks in doctors' minds, that kind of simple mechanistic model. And the idea of dealing with the messiness of life, stresses and human interactions and diet and exercise and mindset is all too somehow, especially for a GP in a 10-minute consult, is all too diffuse and complicated. And so I think that kind of mechanistic model is really what sticks out for people. And, doctors like, neat solutions, I think. I mean, everyone does. Who doesn't want to imagine bulletin? Who doesn't want to walk into a doctor's office, take a complicated problem and solve it with a tablet or a procedure? So I think that's the seductive aspect of medical education that simple explanations like chemical imbalances play into.
And I so can understand that. I mean, we all love certainty, but if you're a doctor and patients are queuing up to come in with their life's problems, you don't want an awful lot of uncertainty there. You want certainty, particularly if you want to sleep at night. So I can understand the allure of that. Back onto antidepressants, Mark, because 1 in 6 Australians are now taking it. And interestingly, I know there was a research article about 20 years ago that stood out for me that showed that they took the 6 major antidepressants and compared them to a placebo for mild to moderate depression and found the placebo was just as effective. So that was about 15 or 20 years ago. But it's sobering to realise that in the last 15 years since that article was published, there's been a 95% increase in antidepressant prescription, or thereabouts. I don't know whether that's exactly right.
That sounds about right to me. That sounds about right to me.
That is quite extraordinary, isn't it?
I think it is extraordinary. I think it's the triumph of marketing over science. I mean, since if you've looked at the literature 20 years ago, not much has changed. There's more antidepressants. There's a few more Me Too drugs. It is still the best studies in the field show that the difference between a sugar tablet and an antidepressant is 2 points on a 52-point scale. But there's a lot of problems with those studies. They're very short term, so no one knows if those effects will last. In those studies, patients on antidepressants will know that they're on antidepressants because of side effects. We know that people that know they're on a medication will respond better. That's called unblinding and expectation effects. We also, and I think this is another central point which a bit speaks to chemical imbalances, is if drugs do have this very small effect over placebo, how do they do that? Because if they do it by fixing the chemical problem underlying depression, well, that sounds pretty good to me. If I had a thyroid problem with too few thyroid hormones and I was offered extra thyroid hormones, I would take it. That seems to me a pretty neat solution to a problem. And I think people think that then antidepressants must fix the underlying chemical problem. But there's a different way of understanding how antidepressants work, which is rather than solving the underlying problem, if you ask people in surveys, how do you feel on antidepressants? The most common response is numbed. They mean that their emotional range from positive to negative has been squashed. And you can see, if you're in the middle of huge uproar, panic, anxiety, depression, that having your emotions turn from a 10 to a 3 might be quite relieving. And you can also imagine how in the long term it may be a problem in itself, because you don't just, if antidepressants are sometimes portrayed as a targeted missile, just going for negative thoughts or negative feelings. But of course, we're not so clever. No one is that clever. What the drugs seem to probably do is to numb global thinking and feeling. And so the number one reason people come to my clinic, where I help people come off antidepressants, is because they have lost the feeling of life. They've lost their enthusiasm. They've lost their interest. It's often affected their relationships, and they don't want to be numbed anymore. That numbing feeling is often correlated with sexual numbing, because of course sexual side effects are very common with antidepressants. And there are studies showing that the degree of genital numbing people experience on antidepressants correlates with emotional numbing. And in fact, the drugs, because I'm writing always about how to come off them, if you crunch up most antidepressants and swish it around your mouth with water, it will anesthetize your mouth lightly. And so I think that these drugs have mild anesthetic effects that affect both your bodily sensation, particularly your genitals, and also your emotions. And I think that is a much more convincing way that these drugs work, which is a very different story. You can imagine the difference between being told by your doctor, this is a drug that will fix the underlying chemical problem in your mood, versus this is a drug that will numb you. Those two things are very different explanations for why they're working. You might say yes to a numbing emotion, but you probably wouldn't be thinking, I want to take this long term. You'd be thinking, I want to get off this as soon as possible, which is very different to what you might think about if you were told that this was caused by, this was going to fix a chemical problem.
That is so interesting to hear you pull that up, because we have done quite a lot of interviews, and we're doing one following yours, Mark, with Dr. Eli Kotler and the psychedelic assisted therapy, which does exactly the opposite. It opens up, it works on what I believe is the default mode network and opens up those connections. Quite the opposite to the numbing.
Right.
Do you have any?
Yes.
Do you have any thoughts on that therapy? I'm sure you
Look,
do.
look,
I may
look,
not.
it's not my area of expertise.
No,
I guess
you
what I
speak with
have,
some authority, Mark.
what I have is I have a slight inherent concern and apprehension about any chemicals that affect a delicate neurological system, because what I feel is there's been a recurring story in psychiatry, which is we have a great new drug. It's going to solve a lot of human emotional problems. It doesn't have many side effects, and it's easy to stop. That was the first round was barbiturates. That was given to housewives in the 1950s. It was said it was safe, effective, easy to stop. It turned out to be not so safe, not so effective, not so easy to stop. It was replaced by benzodiazepines that were said to be safe and effective and easy to stop. They were given out. There was, Mother's Little Helper by the Rolling Stones. It was given out to housewives in the 60s. Turned out to be not so effective, not so safe, not so easy to stop. That was replaced by antidepressants in the 1980s and 1990s, which were said to be safe, effective, easy to stop. It turns out they're not so safe, they're not so effective, they're not so easy to stop. And it happens that as those drugs are coming off patent, a bunch of new drugs come back, which, yes, are old drugs. And there is something appealing about that story, about opening things up and about access to, emotional problems. But I worry these drugs are serotonergic drugs. They act on similar receptors to antidepressants. There's some mild variations. It looks to me like very heavy users of psychedelics look like they have brain damage. They don't have such good memories. They're not so with it. So I have concerns that although it's intriguing on one level to have these drugs that can encourage insight, I spend a lot of time dealing with people that have had serious problems from these medications like antidepressants, benzodiazepines. So I have this inherent concern that with all the hype around this, that underneath it, there's still the worry that these drugs affect a delicate brain and may cause some people trouble. And of course, people do become psychotic. Some people, sometimes the effects are more short-lived than people would like. So I don't want to be the ghost at the feast, because there's obviously a very big feast going on around these drugs. But I would urge everyone to be cautious, and not to dive into the deep end of the Kool-Aid.
Yeah, I don't want to get into that too much, but I would say from my reading of it that firstly, these aren't new drugs. They've been with us through our entire human experience.
Yes.
That we're not talking about recreational use. We're talking about very careful administration and supervision. And it's really unusual to find a therapy where 80% of the people who take it describe it as the greatest experience of their lives or most meaningful. But let's put that aside for a moment, because I know the antidepressants are a big issue. And the other one that I really thought about too was, because there is, and Martin pointed this out in his book very eloquently, the black box warnings on medications, antidepressants for those under 21 or 25, and the suicidal ideation, which is one of the major side effects. And yet in Australia now, not only has the number gone up by 95% in 15 years, but 1 in 30 children, and some as young as 4, are being prescribed antidepressants. I mean, what's your reaction? It must be the same, even worse than your reaction would normally be.
But you're right. Basically, all the issues for adults, are more worrying for children. The effectiveness of antidepressants, which I've just said is pretty minimal, if existent for adults, is even smaller for children. The effects are even smaller. In studies, this is from a big FDA study. They did a big analysis, and they found that people on medications in their studies were more likely to be suicidal than people given placebo, which is very worrying when you're talking about a group of vulnerable children who are already, depressed. There's a story that came, so you're right, it's under 25, there's a black box warning. There's a story that was put out, an explanation by drug companies, and the story goes like this. The reason why people are more suicidal is because they feel better, they have more energy, and the energy comes first before their mood improves, and that's why they've got the ability now to act on their suicidal ideas. But if you wait longer, it'll get better. Now, that is total nonsense. There's no evidence for that. There's no study that shows that energy improves before mood. That's completely manufactured. What the studies show is that children up to the age of 25 who are given antidepressants are more likely to be suicidal than people that are not given antidepressants. Full stop. There's no energy preceding mood stuff. That is a complete line to cover this up. So I think it is very worrying that these drugs are given to children with very poor evidence and very big risks. In America, just this end of last year, they approved an antidepressant for people over the age of 7 for anxiety. And in the study showed that more kids were likely. So the drug was more likely to make kids suicidal than less depressed. So about 10% became suicidal, but only 9% improved in their depression. And the FDA approved it. And the FDA's judgments are very influential around the world. And so it's likely that will affect what the TGA does. So we have written furious letters about this study because it's completely nonsensical to approve a drug that is more likely to make your child suicidal than less depressed. I mean, that is completely, in my mind, madness. So I'm very worried about prescribing medications to children. We don't know how it affects the developing brains. We know we know in animals that giving antidepressants affects the development of their sexual organs. But we don't know what it does in children because no one's ever looked. So I think we are running an experiment that we do not understand, and we're running it in our children.
Gosh, Mark, that is so sobering, and even more sobering when I have done an interview with a professor of pediatrics where I asked him about use of novel medication on children. How can you justify it? And he said, and I quote, "How will we know it works if we don't try it?" It's quite frightening. But listen, you are more focused on some of the myths, some of the misconceptions. One of them is withdrawal effects are only mild and last for 2 or 3 weeks, with any severe symptoms interpreted as a relapse in depression. So what's your response to that?
So, I've just rewatched Dope Sick about the opioid crisis in America, which is a brilliant. I mean, I'm a big fan of Michael Keaton.
Me too.
But it's brilliant. It's a brilliant capturing what happened. And at the heart of that was misinformation put out by drug companies. There were excellent marketing lines. And the opioids is a very extreme example because it's obviously a very deadly medication, and antidepressants are not so deadly. But the themes are the same. It's about misinformation planted by drug companies, and they did a few very clever things. That you don't become a $1.5 trillion business without being very clever. So what they did was, what happened was the antidepressants were released in the 1980s. 1987 was the first, was Prozac. By the early 1990s, there were stories about withdrawal effects from antidepressants. People were writing into medical journals about the issues that were being had. And the drug companies got very nervous because Valium, benzodiazepines, had been a huge market that had been badly impacted by withdrawal effects, dependence on withdrawal. It was happening again, and it was a nightmare for the drug companies. So what they did was they convened a consensus panel in the 1990s where they got the big shots in America and England, the KOLs, the key opinion leaders, the Kim Kardashians from Harvard and Stanford and Oxford, and they wrote a series of papers describing withdrawal effects as discontinuation effects, a euphemism, sort of like describing a car crash into a wall as a discontinuation event involving a wall. It sort of makes it sound much less worrying. And they described it as brief and mild in all these scientific papers, which they distributed to doctors around the world. And those studies were based on people who'd been on antidepressants for 8 weeks. So if you're on antidepressants for 8 weeks and you stop them, it's true to say that mostly the symptoms are brief and mild. Not everybody. Some people have severe effects, but mostly it's brief and mild. So it's a true statement. It's just completely irrelevant to most people because out there in Australia, the average period of time people are on antidepressants is 4 years. And so it's a little bit like doing a crash test with a car and showing that at 5 kilometers an hour, it's extremely safe when it hits a wall. But people out there are driving at 80 kilometers an hour. And so that's exactly what's happened. The longer you're on this medication, the harder it is to stop. The more severe the withdrawal effects, the longer they last. And so in real life, people have months and even years of withdrawal effects. They can be very severe and they're very common. But the guidelines for many years said that the symptoms were mild and brief based on 8-week studies. And it's only the last few years in England that the guidelines have changed, and in Australia they haven't changed. They still say brief and mild, and because of that, that makes doctors very misinformed. That means when a patient walks into your office and they're saying, I'm having severe, long-lasting effects, you look at your textbook, it says brief and mild discontinuation symptoms. This can't be that. It must be a mental illness of some sort. It must be their anxiety or depression. And so this leads to a cycle of misdiagnosis where withdrawal effects are misdiagnosed as a relapse or return of people's condition, which leads to their being put back on the drug. So it becomes a revolving door where trouble coming off the drug leads to being put back on the drug. And that's a very big issue in medicine.
What about antidepressants work by growing new brain cells? I mean, that's another one, isn't
Right.
it?
So for a long time, the main explanation of how antidepressants work was they correct a chemical imbalance. To some degree, academic psychiatry has retreated from that. They've said, look, they've even said that was a simplification. It was a metaphor. We don't think that anymore. And the fallback explanation is antidepressants grow new brain cells in the brain. And I did my PhD on that topic. That's what I spent 3.5 years working on in England. Now, what I didn't understand, some of the studies come from animal studies. It hasn't been shown in humans. But what I didn't understand until I left my PhD was lots of things cause the growth of new brain cells that involve damage to the brain. So, for example, strokes cause the growth of new brain cells. Blunt trauma to the head causes the growth of new brain cells. In the same way as if you cut your skin, you get the growth of new skin cells. So what had not occurred to me in 4 years of research was that if you damage the brain, perhaps by a toxic chemical, you can get the growth of new brain cells, which might not be a good thing. And the other thing is, because everyone thinks, well, new brain cells, that sounds fantastic. That sounds like growing a new brain. But, is a house better with more bricks? Is that better for a house? It could be if they're arranged in a loft that increases the price of your house. But if you just have more bricks, in the middle of your living room, is that a good thing? So I think that we have to ask, what are these drugs actually doing? Is it because of damage? Is it repair? Is it useful? And I don't think there's any very good evidence that it happens in humans with medications. It all comes from animal studies. And if it does happen, is it useful or not? So I think we should be a bit more, we should interrogate this idea a little bit more before we say this is a fantastic result.
So you actually did your PhD on this very subject?
I did.
And you were setting out to show that it in fact did. Was that the point? What were you hoping to show when you started, and how did that change when you finished? I mean, you've shared with us that observation.
So my laboratory that I worked in looked at the effect of antidepressants on brain cells in a dish. And one of the big findings by a senior colleague of mine was that antidepressants increased neurogenesis, the growth of new brain cells in a dish. I was looking at, does inflammation affect that? And it does. It makes brain cells die. My findings were, I was looking at, are antidepressants, does it decrease inflammation? And essentially in my PhD, I found nothing. I found it didn't really affect inflammation. I found there wasn't reliable effects on neurogenesis, the new growth of new brain cells. I walked out of it thinking that I was not a very good scientist because I couldn't find what other people were finding. But now that I reflect on things, I think there are very few positive findings in this field of psychiatry. And I think it's more about looking in the wrong place than about my inadequacies as a pipette holder. So to some degree, I think the entire basis of biological psychiatry is based on a category error of mistaking the mind for the brain. I think that a quick analogy is, if you had a problem with your Microsoft Word and you called in a software engineer to help you out, and they started opening up the back of your computer to look at the circuitry to work out, got out soldering machines, you'd fire him in a second because you think this guy doesn't understand what's going on. But we are doing exactly that when it comes to things like depression and anxiety. All the studies show an incredibly strong correlation between what is happening in your life and your risk of depression. If you add up the number of stressful life events you have, divorce, job loss, poverty, the more you have, the more likely you are to be depressed. It's about responses to life. But we are obsessed with looking for the chemical equation of depression, looking at what's the amygdala doing, what's the hippocampus doing. And I think we are missing the point in the same way as the software engineer opening up the back of the computer. The issues are, our emotional lives, what makes us feel secure, what meets our emotional needs, what our degree of security in life. And I think that looking in the hardware to try to find what is wrong in the brain is looking in the wrong place. I think it's a category error, and I think that's why we have gone down such a mistaken road when we come to treating anxiety and depression.
I love that metaphor. It's lovely. But listen, it is, you are making the point that it is life events which is the main driver. But of course, you mentioned also inflammation there. And I know you were looking at inflammation in terms of its effect on brain cells. But in a broader sense, do you feel that inflammation has a role to play in how well we deal with life events?
I don't think so. Maybe not the answer you were looking for.
Your answer was what I was looking for.
I've sort of gone through, I've been very immersed in all this biological psychiatry and neuroendocrinology. Look, when I think about why my friends, when they're happy, why they're happy, when they're depressed, why they're depressed, I feel it's mostly about their lives. If people have their emotional needs generally met, they're generally pretty happy. If people have their emotional needs not very much met, they're generally pretty miserable. So I think about mood and anxiety as being a readout of the degree to which your emotional needs are being met. To give it in 30 seconds. Yes, there are different set points. Some people are more sensitive to people than things than others. Does it come down to level of inflammation? I does recognize that yes, exercise and diet does influence people's emotional resilience. So I think that plays a role. Is inflammation epiphenomenal? Is it caused by that? Is it a result of emotions? I'm not sure. All I know is that there's a part of my field that tries to treat unhappy childhoods with anti-inflammatory drugs. And I think that's mad, to be perfectly honest. There's a very big groups of researchers that try to give ibuprofen and other anti-inflammatories to depressed people to try to improve their mood. And I think that, that's pressing the wrong button. Maybe unhappy childhoods does make your immune system a bit dysfunctional, but I don't think you can erase an unhappy childhood with an anti-inflammatory drug. So I think there's something is being mixed. The wrong level is being pressed there. So I'm interested in it, but I don't think that's where the money is. If I had to say where I think it is.
Well, I think when it comes to inflammation, the money is definitely not in giving anti-inflammatories to treat mental illness, but perhaps to explore why a person, what are the causes of the inflammation that a person is experiencing, which leads me into another area that you are interested. I know you are helping people come off these medications, and I know you also have not just a professional interest, but you've had a personal experience. I wondered if you might share with us that.
So I guess I have, people describe people like me as critically minded psychiatrists, critical of a biomedical model. And a lot of the people around me are very clever people who have worked out the issues with these, with the current model through reading and research. I'm not so clever. I only worked it out by being smacked in the face with the limitations of the biomedical model, because, to cut a long story short, when I was 33, thereabouts, I had been on an antidepressant for 15 years. I'm talking about slightly miserable people. I'm one of them. If you've seen a Woody Allen film, you'll see what sort of family I come from, a neurotic, messed up lot. And as a 21-year-old, I was a bit unsure about my medical degree, and I went in to see a GP, and in about 2.5 minutes, I was given an antidepressant, and I took Lexapro, escitalopram for 15 years. When I was finishing up my PhD on antidepressants, which of course I did to try to, in the cliche, solve my own problems. That's why everyone goes into psychiatry. I tried to come off my antidepressant. I've been on it for many years. I had a lot of health problems. I had a lot of trouble with fatigue, with memory issues and concentration issues. And a part of me thought it was because of the antidepressant, and I decided to try to come off it. And I came off it in a few months, a lot slower than guidelines recommended. But I ended up in a world of pain, the most unpleasant period of my life. Unpleasant, an understatement from being in England too long. I had trouble sleeping. I would wake up in the morning in a state of utter terror, feeling like I was being chased by a wild animal, my heart beating, covered in sweat. And I would stay in that state for 10, 11, 12 hours a day, utter terror. I took up running to try to get a bit of relief. I ran until my feet bled. I felt dizzy. The world around me appeared unreal. It went on day after day, then week after week. And at some point I thought, I cannot keep living like this. When I compare what I went on the drugs for, I was pessimistic, I was miserable, I was existentially lost in life. That was a 3 out of 10 compared to the 10 out of 10 I had when I came off the drugs. It was a completely different quality of experience, the worst experience of my life. And I soon realized, mostly by reading about other people's experience, that what I was experiencing was withdrawal effects from antidepressant. And I really hadn't been taught about that very much in my training. As I said, I was reading guidelines that said discontinuation of symptoms from antidepressants are mild and brief for 2 or 3 weeks. My experience was completely different from that. I might have walked away thinking I was a very unlucky chap from that, except on the internet I found a dozen people with similar stories. Then I found hundreds, and eventually I found tens of thousands of people with similar stories. And I thought, this isn't just me being unlucky. And that really opened my eyes up to, what coming off these drugs looked like. And that's what's led me really to a right hand change in my career. That these drugs that I had been giving out, prescribing quite widely, that I had been taught were safe and effective, easy to stop, that I spent 4 years studying in the laboratory. Actually, I came face to face with the reality of these drugs and realized it was quite different to what I'd been taught.
Wow, what a story! And which you are now focused on helping people come off that. And one of your initiatives, I noticed, is Outro Health. Can you tell us a little bit about that?
So since I had that experience, I've done a few different things to try, because what I understood from this is I had a very bizarre experience. I was at that time finishing off my PhD at the Institute of Psychiatry at King's College London. While I was there, it passed Harvard as the most cited research institute for psychiatry in the world. So I was working with the top professors in the world. I had just finished a PhD in how antidepressants work. So I was in the scheme of things, pretty highly qualified when it came to antidepressants. I learned how to come off an antidepressant from a retired software engineer on a peer support site. In other words, I was being taught, how to look after my own health with these drugs, by people that were not medically qualified on peer support sites. I thought, this is the most bizarre thing that has ever occurred to me. I'm a very institutionalized person. I've got 6 academic degrees. I am used to listening to professors. I've sat in lectures at theaters my entire life. And I thought, what is happening? And the response, I did a couple of things happened from that. One, I actually worked out people online were saying things that were more accurate and more helpful to me than what I was reading in academic articles. And I took their advice. And I've managed to come off that drug because of the advice that I was given. I came off a lot slower, over many years, going down in very small amounts, using a liquid version of the drug in a technique I learned from them. And I thought, I have to, how can this be happening? I need to tell other doctors how to deal with these issues. And so I wrote an academic article about what I'd learned on those websites. And that article was published in the Lancet Psychiatry, which is a good journal, a good European journal. And that led to a guideline change in England, where the guidelines now recommend what I had put forward, coming off much more slowly, often using liquids, being much more careful about the way you come down. It started to lead to a culture change in England, where there is more awareness of these issues. The government has asked for clinics to be set up to help people come off the drugs. I run the first such clinic in the National Health Service in England to help people to stop antidepressants. What happened after I wrote that article was I began to get hundreds of emails. Then I got thousands of emails. Before that, I'd written 15 articles. I got 1 email. But after I wrote the article about antidepressants, I got 7,500 emails in the first year after that article. And a lot of them were from Americans and Canadians and people around the world asking me, can I help them to come off their medication because their doctors didn't know how? And I thought, this is utterly bizarre. I'm a research fellow in London, and people in America are writing to me to help me come off their drugs. And I thought, there's something deeply wrong with what's going on. We've since surveyed these people, and we find, doctors don't recognize withdrawal. They do it too quickly. They misdiagnose relapse. And basically, a couple of years ago, some people involved in medical clinics in America approached me to say, can we set up a clinic to help people stop antidepressants in America? And I said, please, it'll empty my inbox. And so we set up a company called Unstress Health, which is aiming to open in California a clinic to help people safely stop antidepressants in the second half of this year, doing the kind of thing that I do in my clinic in London, which is taking people off much more slowly than other clinics do, doing it in a much more individualized way, and giving people a bit of support, because it can be quite an unpleasant experience. And that's what we're trying to do. I'd love for Australian medical culture to follow that, just to take on some of the improvements in English medical guidance. But so far, I've seen not much evidence of that. There's a few bright spots. There's some fantastic research being done in Queensland by a professor called Catherine Wallace, who is doing a great study on this technique. I think she's a real trailblazer. She's a very, very effective researcher, great clinical leader. And I think people like her are paving the way for the future in Australia. And I hope more people will pay that sort of work attention.
You mentioned that's an astounding story, Mark, given your academic background, not only in terms of qualifications, but where you achieved them, to have received this advice online from a software engineer. Was the key the time it took to come off it? And if so, what's the difference between what your doctor said and what the software engineer informed you?
So there's three principles to coming off these drugs. And you're right. Number one is the speed. The guidelines say come off over weeks. But what we found from research and my own experience is it can take people months, more than a year, and even several years, because people are on these. If you're on the drugs for a few weeks, you can come off in a few weeks. But most people are on the drugs for years, and your brain becomes incredibly accustomed to the drug, and it needs time to adapt to there being less drug about. And that can mean that it takes months or years of slowly reducing the drug. The second principle is it's got to be at a rate people can tolerate. Everyone's a bit different. We don't have enough research to say who's going to take 6 months, who's going to take 18 months. So you need to take an approach that's adjusted to the individual. If they can handle it, go a bit quicker. If it's too much, go a bit slower. And the last point, which is really what my research has focused on, is very small doses of antidepressants have outsized effects on the brain. There's this, for people who are looking at this as a video, it's a curve called a hyperbola. Very small doses have large effects. So, for example, a very common antidepressant is citalopram, Celexa. 2 milligrams of Celexa has about half the effect of 20 milligrams. It sounds like a tiny dose, but actually these tiny doses have big effects. The smallest available tablet is 20 milligrams. It means that to come off these drugs, it's almost impossible to do it with the tablets. Even if you halve them or quarter them, it's still very hard to get down to these tiny little doses at the end, which is why a liquid version of a drug or a specially compounded tablet to make these smaller doses is so important. Because what happens is people fall off. It's like a cliff. It starts off, you're walking down quite a nice path, like a country walk. It becomes steeper and steeper. And right at the end, it becomes like a vertical cliff. And people fall off this cliff, this last bit of the drug. These last few milligrams are the hardest to come off. And what people need to do is to come down very slowly at the end, often tiny percentage of a milligram at a time to come off the drug. And that's what I learned. I fell off that cliff to start off with, and I've come off it a lot more slowly. And what we find in our clinic is people that have tried several times to come off without success with this technique, slower, over months and years, at a rate they can tolerate, and very carefully at the end, are able to come off. It takes them a lot longer, but they get off. And that's been very gratifying to be part of.
And I notice on the Outro Health site, it makes some reference to holistic wellness practices. What does that mean to Outro Health, to you? What does that mean to you?
So look, one question people ask is, so if antidepressants are not the answer, what is the answer? And I've got two answers to that. My number one answer is there's not a one size fits all, because that's what chemical imbalances, and it turns everybody's problem into the same problem. Wherever you are, it's a chemical in your brain. So I'm wary of those kind of descriptions. People are depressed for a reason. I would go back to the DSM-1 and 2. It's a reaction to things in life. People are upset because of relationship problems. People are upset because of job issues. People are upset because of illness. So everyone's problems, I think understanding why people are depressed is the best way to help them. If it's relationship, they might need relationship advice. If it's financial issues, they may need financial assistance. So I think the first thing is meet the person where they are, understand what their issues are, and that's the best way to help them. And then in general, I think there are things that are helpful for everybody. And, those are the, non-medication lifestyle things. And I don't just take my word for it. In the NICE guidelines, so NICE is a government department in England that determines what is effective treatment for all sorts of conditions, from diabetes to depression. And in the NICE guidelines, there are 21 equally effective treatments for depression, for both mild and severe depression. 3 of them involve antidepressants and 18 of them don't. And those 18 treatments involve exercise, group exercise, various forms of therapy, mindfulness. But the single most cost-effective treatment out of all of them for depression, for severe depression, is problem-solving therapy. And problem-solving therapy means writing down your top 3 problems, what is the first step you're going to take for each of them, and come back in 2 weeks and tell me what you've done about the first step, which I think really speaks to, being the issues in people's lives that drives depression. But, it's also, you've talked about the holistic pillars of health. So I think there's a lot of things that people can do with diet and exercise and social contact and finding ways to relax oneself, whether it's mindfulness, whatever people do, that can make people, more able to deal with the ups and downs of life. And I think that they're poo-pooed in medical training. It's not real stuff. Real stuff involves chemicals and scalpels. But I think in the long term, those sort of approaches have profound effects on people's lives, whereas things like drugs wear off, because I think that's another big limitation with studies. Studies often go for 6 weeks. Now, at 6 weeks, a lot of things are equally effective. Exercise, depression, therapy, medication. The trick is medications wear off. All medications cause tolerance. We become used to them. So the effects of drugs wear off. But skills like therapy is learning, how to think about your life, how to manage your emotions. Exercise, how to be healthy. Those are things that can improve. You can improve skills over time. And so in the long term, there are not long-term studies that I know of about exercise, but for therapy, for example, after a year, therapy is vastly more effective than antidepressants. And I think that those sort of holistic pillars probably fit into the same category of things that you can improve over time that probably reap benefits in the long term.
Now, listen, I just want to finish up with one last question, Mark, because taking a step back from your background in academia, in study as a psychiatrist, we're all on a health journey in this modern world as individuals. What do you think the biggest challenge is for us as individuals on that journey?
Okay, it's a big question. I think about my life, if I can use the prism of my life to understand things, I think me learning to take care of my own health has been a very central part of things. So I think of myself as a distressed 21-year-old that I no longer am. And I think that I was very poorly equipped back then to manage my own health. And I think the things that I've done since then probably do fit into these holistic pillars. I think understanding myself better has been very helpful. I think, getting into exercise, I learned mindfulness along the way. I think I learned a lot about diet. I think all those things, had I known them at 21, it may have put me in a different position to where I am now. I think that's maybe as a part of maturity, is learning the sort of things that you need to do to keep yourself healthy. So I guess what's the message for other people? I guess I think there's a lot we can do for our own health that involves us being, empowered and having agency in looking after ourselves, that makes us less reliant on external help like medications. And I think that's, it always makes me think about my grandmother. My grandmother was an old school Russian, tough guy. And I think that, her response to things was, you got to do an hour of exercise in the morning. You've got to be disciplined. You've got to get things done. And I always thought, what a hard ass. But I think there's a lot of wisdom in that. I think, again, I'm not saying to people to pull themselves up by their bootstraps, because that's not, I don't subscribe to that. But I do think there is a lot we can do for ourselves that can make us more resilient against the troubles that we're inevitably going to experience in life. And I think that speaks to both physical and mental health in general.
Mark, thank you so much for joining us today. I've been so looking forward to this conversation. Thank you for sharing your knowledge, wisdom, and sharing your personal story as well.
Thanks for having me on, Ron. It's been good to talk to you.
Well, as I mentioned, this is a big topic, and a topic, while we were discussing mental health, really, when we talk about the influence of key opinion leaders and product champions who actually occupy very, very senior roles in our healthcare system, from bureaucrats to academics, from editors to professors of health. The key opinion leaders and product champions play an extraordinarily important role. And that role is, let's put it this way. If the evidence is anything to go by, and we're told it is, then we have an epidemic of preventable chronic degenerative diseases. And that evidence would suggest that perhaps our approach to not just mental health, but health in general, is not all that it should be if we were really focused on the evidence. Now, I should have mentioned that Mark also co-wrote a clinical handbook called the Maudsley Prescribing Guidelines, which outlines how to safely stop antidepressants, benzodiazepines, which are things like Valium, and sleeping tablets. It is aimed at GPs, psychiatrists, pharmacists, and anyone involved in the care of people taking these medications. And I'm assuming that includes people actually taking these medications. We also are aware that patients are buying it to give to their prescribers and to better inform themselves. Absolutely. Inform yourself. It's available on Amazon. We will have links to that book in our show notes. So I hope you enjoyed that conversation. Very stimulating, some very important concepts that we discussed there. I encourage you to join the Unstress Health community, which is independent of industry, be it chemical, food or pharmaceutical industry. And if I had to say anything, the key opinion leaders who are involved in this platform, as in myself and the advisory panel which supports me in that, well, I can assure you there are no links to industry. Your health is all that is important to us. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.